like the lifeblood of nursing. Vital signs give you so much information that you wouldn't believe how much information you get from vital signs. It's the beginning of every assessment you do. You take vital signs. So we're going to talk about the anatomic structures that are involved in the vital signs and how the vital signs are regulated in your body. We're going to list factors that affect your vital signs. You will demonstrate measuring and recording in lab. I'm going to talk normal and abnormal characteristics of all your vital signs, not just your pulse. And we're going to talk about blood pressures. Okay, and we're going to determine factors that might adversely affect your temperature, pulse, respiration, or blood pressure. So there are 5 vital signs, right? Temperature, pulse, respiration, blood pressure, and then pain level. Now, the Joint Commission says that we need to include a pain assessment with every set of vital signs. It is not necessarily a vital sign, but that is an assessment we do with the vital signs. So they give us an indication of the health status of the patient. We need to know age variables so that we know whether this is right or wrong for our patient. And accurate measurements are required. If you have designated somebody else to take your vital signs, please, please, please make sure they're doing it correctly. I once had a situation where I sent an aide off to do vital signs on my 16 patients. And I don't know if they were just angry because I asked them to do it or what. They all came back with a blood pressure of 120/80. Every single one of them. 16 patients with a blood pressure of exactly 120/80. Do you guys see anything wrong with that? Yeah, me too. I was not pleased. All right. So please make sure that whoever you're sending off to do your vital signs for you, you can trust that they're going to do a good job. So as we get older, our vital signs change. Older adults get more heat loss because that leads to hypothermia because they have a lower basal metabolic rate. They also have less subcutaneous fat, which is what keeps us insulated. So they lose heat faster. Hypertension, okay. A lot of older adults have high blood pressure because of the hardening of the arteries. Everybody's arteries harden. There's nothing you can do about that. We can keep them from getting clogged by cutting down on cholesterol, but everybody's arteries do eventually get harder. So we'll have an increase in blood pressure with older people. Older people also have different respiratory rates because they're not breathing at their full capacity because, the cartilage hardens up a little bit. They can't expand their chest as well as you did when you were younger. So that's another thing that you will see a change in. There should be no change in heart rate, okay? Your body produces heat through your normal body metabolism. Heat is one of the byproducts of cellular respiration. When your cell uses the energy, it produces heat, okay? Metabolism increases, heat increases. So when your body is invaded by pathogens, when we're getting an infection, okay, your body will automatically raise the basal metabolic rate, okay, in order to get rid of those pathogens. Remember, fever is one of the first things that happen until your white count can catch up, okay, until your other defenses get there. Your body elevates its temperature to try and burn off some of these pathogens. Okay. Things that affect your body heat production, your thyroid. Too much thyroid hormone, you're going to be too hot. Not enough thyroid hormone, you're going to be too cold, okay? Also, your hypothalamus is also responsible for your body heat regulation. That's in your brain. Other hormones, epinephrine and norepinephrine, those are the hormones of sympathetic, parasympathetic nervous system, right? And then testosterone. So men are going to have a higher temperature than women normally. Not, really high, but maybe a half a degree or so. We know that voluntary muscle movement causes increased heat. So, when you work out, you get warm, right? If you're walking, you get warm. If you're just sitting, you're cold. And then shivering increases heat production 5 times normal. So, excuse me, that's the boss. Yes. Who? Yeah, I believe she was there last night. Okay. Okay. Thank you. Yes. Yes. Well, Lynn is in class right now. Okay, I will do that. Thank you. Bye. So sorry, that was the boss. Shiver, we're going to add more heat. Body heats itself up. And we do it through great means from duck at it.
It keeps muting.
Sorry?
Like muting.
I'm not muting. I'm not muted. Are you muted?
No, it keeps muting you and unmuting you back and forth, like coming in and out.
I'm sorry. I'm using my phone because my microphone isn't working. I'll keep an eye on that. Okay. So radiation is the emission of heat. It's going away from you. Conduction is the distribution of heat. You're going to stay warmer in your core than you are in your fingers and toes. Convection is the circulation of heat. And evaporation is air movement over moisture, okay, which will cool you down. So that's why you sweat when it's really hot, so that the air moves over your sweat and it cools you off. Well, if we have a lot of water loss, if we have a lot of sweat, otherwise we're going to get colder, not warmer. Okay, so hyperthermia, hyper means up, right? So hyperthermia, the temperature is above normal range, and we call that a fever or a febrile state or pyrexia. These terms are things you need to know because you're going to see them in exam questions. All right. Hypothermia means lowering of the body temp, the entire body temperature, not just your fingers and toes, everything. So your hypothermia means your body temperature is lower than 94 degrees Fahrenheit. Now, if your normal temperature is 98, that means your body temperature has dropped 4 degrees. That's a lot. People who are at risk for hypothermia are infants. We know we need to keep them warm. They can't keep themselves warm. Surgical patients in the operating room because it gets really cold in there. Elderly who are exposed to cold for long periods of time. And when you're thinking this, think of somebody who wanders outside in the middle of winter, not dressed properly, okay? This is what usually gets them in trouble is the cold. People exposed to extreme cold weather and those exposed to cold water immersions. Okay? So those are the people who are at risk for hypothermia. Pyrexia, or a temperature, is a temperature higher, and this is 100.2. We usually use 100.4. I do believe your book says 100.4. Okay? You do not have a fever until the temperature is over 100.4. All right, so if it's at 100, it's not necessarily a fever. It's your body trying to do its work. Pyrexia occurs when normal regulation mechanisms cannot keep up with the heat produced by the body. So pyrogens, bacteria, pyrogens meaning we generate heat. Bacteria causes increase in body temperature. And then diaphoresis. Diaphoresis is excessive sweat. This is another word that you're going to see a lot. Diaphoresis. Excessive sweat produced to cool the body. So what are we going to do to reduce the fever? Okay. We want to make sure that we increase our patients' fluid intake, because you know the higher their temperature, the more water they're going to lose. We're going to get dehydrated. So increase their fluid intake. Lower the room temperature. How many of you who work in long-term care walk into a room and it's about 98 degrees in there and they're sitting there with a blanket and a sweater on? Right? All the time. And then you take their temperature and it's like 99.9. Take off some of the clothes, decrease the temperature in the room. Their temperature will go back down to normal. Okay. Control the amount of body activity. So if you have somebody who already has a fever, we don't want them up wandering around and using those muscles to get hotter. Sponge bath or a cooling blanket or something you can do without a doctor's order. All right. And then the antipyretics, okay, your aspirin and your acetaminophen are medications that the doctor has to order in order to get rid of the fever. So all those things up until that antipyretics you can do as a nursing intervention. All right, you don't need a doctor's order for that. When you do have a fever, you want to check the temperature at least every 4 hours to make sure it's not getting worse. All right. So normal temperature here, see, it's between 104 and 96.8. Normal temperature, 96.8 to 100.4. That's the range of acceptable values. Older people will be down here closer to 96.8, okay? Younger people and healthy males may be a little closer to 100, but it's all normal, all right? If you get under that, then we're talking about hypothermia, right? Temperature regulation issues, cardiac dysrhythmias, etc. All right. Anything higher than 100.4, we consider febrile or a fever. But they could also, if they're up in the 110s, 113s, then we're talking about heat stroke, those kind of things. So, and don't forget to, when we talk about our Celsius, a lot of facilities use Celsius instead of Fahrenheit to record their temperatures. So you're going to have to know how to convert that, and we'll talk about that in math. So it's important to know the patient's usual temperatures and then compare the changes. So if somebody's normal temperature is 96.8 or 97, and you take their temperature today and it's 98, that's a little higher than normal, right? You have to know their normal temperature. If, you know, they may not appear to have a fever, but if they're a couple of degrees higher than their normal temperature, they're working on something. You need to work on that, okay? Depends on what kind of measurement device you use. If we use a rectal thermometer, temperatures are about 1 degree higher than an oral temperature. And axillary temperature, where do we take axillary temperatures at?
Armpit.
Yeah, that goes under the arm, okay? It's usually about 1 degree lower than oral. And then tympanic membrane measurements, where do we
It's
take
on
those at?
The temple.
on the
Nope.
forehead here.
Nope.
Yes.
Tympanic, ear,
Mhm.
okay, your tympanic membrane. Tympanic temperatures are actually core body temperatures, all right? They're not surface temperatures, it's a core body temperature. Rectal temperature is a core body temperature, all right? So we have glass thermometers, we have electronic thermometers, we have disposable thermometers, all of which you're going to see in your practice. Usually the glass thermometers will be in home care, all right? The rest of them will be in your practice, okay? When you're taking an oral temperature, the tip of the thermometer has to be in the sublingual pocket. Where is the sublingual pocket at?
Under the tongue.
Under the tongue, yes, not in the cheek, under the tongue. Always use a cover on your thermometer, okay? So that you're not contaminating the probe, so we can use it on somebody else. If you're taking a rectal temperature, and we're going to go through this in lab, so I'm not going to worry about it. Yeah. So here's your temporal arterial skin temperature. This is the one that goes across the forehead. All right. That's an oral temperature. See where they're putting the probe cover here? You're all familiar with the electronic thermometers. And this is an old-fashioned. It does not have mercury in it anymore. It has gerotherm in it. But this little line here is what goes up and down when you're taking the temperature. And so you will see it rise. And usually if it's somewhere here in this red area, you're okay. Anything higher than that, you have a fever. Okay. And it goes up by 2, 96, 98, 100, 102, etc. You always have to shake those down. You shake them so that the level of the level of the material is below 98.6. Okay. Record your temperature in even numbers unless you're using an electronic thermometer. And then when we document them, this is one type of documentation. This is what we use for our simulation. All right. This is nice because if I put my Fahrenheit number in here, it'll automatically put the Celsius number in. It's very good. But we also want to know where you took your temperature. What site did we use? Was it oral? Was it rectal? Was it axillary, etc.? And then this will show up on a chart over here. And when you get more, you can see if it's staying steady, if it's going down, or if it's going up. So that's thermometers, that's temperature. Temperature is controlled by body metabolism, your hypothalamus, some hormones, right? Okay. Your pulse. Your pulse is produced by the cardiac contractions. It causes pressure wave against the walls of the artery. So it's like a wave. When the heart pumps, it pushes out blood. What you're feeling is that blood being pushed out. Okay. Usually, each contraction will propel 60 to 70 milliliters of blood, which is about 2 ounces. All right, a little over 2 ounces. All right. And what we need, that is your stroke volume. That's the amount of blood coming out as stroke volume. And that affects your pulse character. If you have more blood being pushed out, then your pulse is going to be harder. Less blood is going to be thready. If we take our stroke volume times our heart rate, then we're going to have our cardiac output. So know what stroke volume is and know what cardiac output is. So we normally check our pulse by palpation, which means we're touching, right? Or auscultation, which means we're listening with a stethoscope. The pulse rate can be affected by fever, pain, hypoxia, anxiety, exercise, and cardiac disease. But the rate normally does not change with age, okay? Dysrhythmias are common though. Dysrhythmia means that we're not having a regular heartbeat, okay? It's like boom, 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 okay? So the average pulse rate in an adult is 72 beats per minute. That's the average, but it can be anywhere from 160 to 100 is your range, okay? So tachycardia, tachy means fast, right? So tachycardia, your pulse is greater than 100. Brady means slow. So that's less than 60. When we talk about a pulse deficit, we are talking about the difference between an apical pulse, which is when you listen to the heart on the chest, and the pulse that you palpate on the arm. They should be pretty close. If they're not, then there's a problem with the circulation somewhere after it leaves the heart. Okay. So factors that affect your pulse rate. It says age, but we already know we said that didn't happen. Body build and size. Your blood pressure will affect your pulse rate. Higher the blood pressure, the lower your pulse, usually. Okay, so there is an inverse relationship there. Drugs can affect your pulse. Some of the heart medicines keep your pulse low. Some of the other drugs make your heart race, like your respiratory drugs. Your emotions, blood loss, exercise, increased body temperature, pain, and hypoxia. What is hypoxia? Who can tell me what hypoxia is?
Lack of oxygen.
Right. Very good. So when does that happen?
Possibly poor gas exchange.
Yes. Or gas exchange. That's a good one.
Low respirations.
Yeah. If you're not breathing in, you're not going to have a lot of oxygen in there, right? All right. So when we're talking about your pulse, we're gonna not only notice the number, we're gonna talk about the rate, the rhythm, and the volume. The rate is obviously how many beats per minute we hear or if we feel. The rhythm is it regular? A heartbeat should be regular. Okay? You should not hear or regular. Hold on. Okay? And then the volume. Is it like bounding where you can basically see the pulse pounding on the hand? Or is it really thready and you can barely feel it? Okay, that's the volume. So when we're looking at strength of pulse, weak and regular, even, those are beats that have poor force. We are talking about a 1+. We document it as 1+. Strong and regular, what you're normally going to have is a 2+. And then full and bounding, so it's even beats, but it's really strong, is a 3+. We can also use words like feeble when we're documenting, or irregular. So you have both strong and weak beats. Thready indicates it's weak. It may also be irregular. And absence means we have no pulse palpable or heard on auscultation, which I would think would be a big problem, right? So these are terms that you're going to use to document what the pulse feels like to you when you take it. So here is where you're going to assess the radial pulse. It's right underneath, let me find my camera, okay. Right underneath your thumb on the side of your arm, okay? You feel the pulse there. You kind of want to move that artery up against the ligament. It'll be easier to feel, okay? The other place you may take a pulse is your carotid artery, which is the one in your neck. We do that in an emergency, right? But normally we do it on the arm. And that's the radial artery. So the radial artery at the wrist, the base of the thumb. Temporal artery is right in front of your ear. Can you feel the pulse there? Up here in your temple? I don't think I have any blood going to my head. Okay, there it is. Carotid is on the front side of the neck, so you want to go up against the trachea. Femoral artery is in the groin. Your apical pulse is at the apex of the heart, which is the bottom of the heart, okay? And to find that, you're going to count down 5 intercostal spaces. So when you feel your chest, let's see if I can get this to go down. I guess I'll stand up a little bit. In between, intercostal means in between your ribs, okay? You can feel your ribs and there's a space above it and below it. Count down 5 of those. Okay, so you're gonna get down here, all around under your breast, okay? And then you're going to go mid-clavicular, which means the middle of your clavicle, okay? Down And you're going to put your stethoscope right about here. So it's mid-clavicular line in the fifth intercostal space to hear the apex of the heart and get an apical pulse. If you have an irregular radial pulse, you need to listen to an apical pulse for 1 full minute. Popliteal pulses behind your knee, and your pedal pulses are on your ankle, the inside of your ankle, behind your ankle bone, and on the top of your foot. So these are all your pulse points now, okay? When you're listening to your, well, we already told you where you're going to listen for your apical pulse, okay? And you're going to hear 2 sounds. You're going to hear S1 and S2, and that's your lub-dub, 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 lub-dub. That's what it sounds like, actually, and you'll hear it later. And then when we record our pulse measurements, we also want to record where we got it from. Was it a radial pulse? Was it a carotid pulse? Okay. Was it an apical pulse? Okay, so we've talked about temperature, pulse, and respirations. This is respirations, okay? You can't control your breathing. You may control it for a minute, few seconds, but your body's going to breathe whether you want to or not, okay? So it's involuntary. And it's caused by the respiratory center and the pons and the medulla, and those are in your brainstem at the back of your head. And the reason you take a breath is because you have increased level of CO2. If your blood has too much CO2 in it, your body's going to take a deep breath in order to get oxygen in, and so it can exchange in the lungs. The CO2 comes out, the O2 goes in, and then you have another minute or so, a few seconds between the next breath, okay? So there are different receptors in your body, and you'll learn about those in A&P, okay? But in order to maintain normal oxygen, carbon dioxide, and hydrogen levels in your body, this is why your body takes a breath, to maintain those. It's all about homeostasis. When you're assessing respirations, you're going to count both the inspiration and expiration as one respiration. They take a breath in, they let it out, that's 1. Take another one, let it out, that's 2. Okay, you're gonna watch the chest wall go up and down. That's 1 respiration. And when we're doing this, we're going to start with the pulse, right? You're gonna take your pulse and you're gonna count that for 30 seconds. You're gonna hold on to their wrist after that and look at their chest and count the respirations, because nobody's gonna breathe normally if you're staring at them. If you are staring at them like this, they're gonna just like stop breathing, okay? So do not do that. That's why we hold on to the wrist and pretend we're still taking a pulse while we count respirations. And yes, you have to hold 2 numbers in your head. I'm sorry, you can do it, you're nurses. All right, so we're watching 1 up and down, that's 1 respiration. We're also going to look at the outside of the rate, which is the number. We're going to see how deep are they. I'd be willing to bet that none of you took a deep breath since like 6 o'clock this morning, okay? Everybody breathes shallow when they're stressed, okay? So deep, how deep is the respiration and the rhythm? It should be regular. There are some really bad things that happen in your head that causes your respiration to be irregular. We'll talk about those in a minute. Okay, so we're going to count for 30 seconds and multiply by 2. If they have irregular respirations, you count for a full minute. So here are some words you need to know. U, the EU, that means normal, okay? So if you have eupnea or they're eupnic, they have normal relaxed breathing patterns, okay? Dyspnea means difficult, okay? Difficult and labored breathing. Tachy is the same that it is when you are tachycardic, your heart rate's too fast. Tachypnea is your breathing is too fast. And bradycardia means it's too slow. Normal respirations are between 12 and 20 respirations per minute. Okay? So eupnea, dyspnea, tachypnea, and bradypnea, you will need to know those terms, so keep them in mind. Then we have hyperventilation. That's where you breathe in and out real fast. You just basically pant, okay? You're blowing off a lot of CO2 when that happens. Cheyne-Stokes respirations, that's dyspnea followed by short periods of apnea. So they have trouble breathing, and then they stop breathing for a little while, and then they start breathing again, and it's labored, and then they stop breathing for a little while, okay? Kussmaul's respirations are really increased rate and depths, and then they have panting and long grunting exhalations. So they go, okay? The Cheyne-Stokes, you're gonna see that when people are actually actively dying. Kussmaul's and Biot's are when they have head injuries. Okay, so, and then Biot's respiration is shallow for 2 or 3 breaths with a period of apnea. So they have a couple of breaths and then it stops, and then it starts again, and then it stops again. Okay, so Cheyne-Stokes has apnea, Biot's has apnea, Kussmaul's does not. And sometimes when you listen to lungs with the stethoscope, you're going to hear some noises. You're going to hear some noises that are not normal. Normally, you should just hear whooshing in and out. Okay? So, if it's abnormal, non-musical, here's like crackles, like, you know, when you pour milk on Rice Krispies and it's just hear that snap and crackling sound. Or if you take your hair and you rub it next to your ear, you're going to hear a crackly sound. All right? That's called crackles or rails. Those are not normal. Bronchi is the dry, rattly sound you hear when somebody's really congested. It's in the bronchial tubes. Stertor is snoring sounds produced when they're unable to cough up secretions from the trachea or bronchi. Okay? It's an intake. Stridor is where you hear that crowing sound. Anybody ever hear a child with croup or whooping cough? Okay, where their airway is pretty much obstructed, and then it's that crowing sound on inspiration. Okay, and then wheezing is whistling sound like a musical high-pitched note when they're breathing, and that means that their airways are restricted. When we're recording respirations, everybody knows they're only in the chest, so you don't have to put a sight, but you do need to count for 30 seconds and multiply by 2, okay? And the other part of your respiratory assessment is going to be oxygen saturation. This is where we put the pulse ox on the finger, okay? Normally on the index finger, you can move that around to different fingers. Just make sure if it's on for a long time, we're not getting a pressure ulcer. Okay, and the machine, it measures, actually it's sending a light through your finger and it's counting hemoglobin that has oxygen on it. So the probe attached to the body area, infrared and red light reaches the capillary bed and it counts how much hemoglobin you have with oxygen. Okay. Now blood pressure. Blood pressure is the force that's going against the arterial walls when the heart pumps. Okay, it's affected by the condition of the arteries, the circulating blood volume, the cardiac output, and changes with age are normal. The older you get, the higher your blood pressure goes. When we say systolic, we're talking about the top number, and this is when the heart contracts. So when the heart squeezes, that's your systolic. That's the whoosh of blood that comes out. Diastolic is when your heart relaxes, because you know it relaxes between heartbeats. So when it squeezes, we get our systolic pressure. When it relaxes, that's the diastolic pressure. That's the amount of force on the arterial wall between contractions. So if the blood volume is decreased, okay, your blood pressure is going to decrease. If you don't have enough blood to push around, there's not going to be as much force when the heart pushes it out, right? So people with dehydration or hemorrhage, their blood pressure is going to be pretty low. If your blood pressure, if you have excess fluid, you have overload, fluid overload, your blood pressure is going to rise because there's more force on the arteries. So average blood pressure, 120 over, it's usually 120 over 80, okay? And that's just an average. We never tell somebody they have hypertension until we've gotten 3 blood pressures that are high on 3 separate days, okay? 120 is the systolic, 70 is the diastolic here. Anxiety, fear, and stress elevate the blood pressure. So when you're taking somebody's blood pressure, you want them in a quiet, relaxed environment. Have them sit up or lay down, but their feet need to be on the floor. If they're sitting, they can't cross their legs. They shouldn't be talking. They should be nice and quiet, sitting there. You know, those of you who are medical assistants in doctor's offices, this is what drives me nuts. They take you to the room, they get you on the scale. I'm already upset because my weight's up, right? They sit me on the table and take my blood pressure. They don't give me a chance to relax. They don't give me a chance to take a breath. And then they say, oh, your blood pressure's high. Well, yeah, duh. Give me a minute, okay? So when we are assessing arterial blood pressure, okay, the cuff is going to go above your elbow, okay? And it should be like 2/3 of the length of your arm between your shoulder and your elbow, okay? And it should fit the circumference of the arm. Blood pressure cuffs come in different sizes. And if you have a blood pressure cuff that is too small for your patient, their blood pressure will record as higher than it is. What you're listening to when you take a blood pressure or what we call Korotkoff sounds, okay? So the first thing you're going to listen for is a pop or a tap, because that's the systolic number. The first sound you hear is the systolic number. And then you're going to listen, and you might not hear anything for a little bit, and then hear some swishing and some knocking and a little muffled sound, and then it goes silent. When it stops, when you stop hearing anything, that's your diastolic number. Okay? First sound is systolic, the silence is your diastolic. Okay? So hypertension is pressure consistently above the normal range. Okay, so usually above 140 and above 90. And we want to worry about prolonged hypertension because it can cause permanent damage to your brain, your kidney, your heart, and your retinas. Low blood pressure is 90 over 60. Anything 90 over 60 or lower is a problem. They don't have enough blood moving. Okay? And then postural hypotension is when you go from laying down to sitting or standing, and your blood pressure is going to drop 10 millimeters of mercury. So if you're lying down and your blood pressure is 120 over 80, and then you sit up in bed and your blood pressure changes to 100 over 60, that's postural hypotension. So the blood pressure drops when you change position. And when we record blood pressures, the systolic number is always on top. The diastolic is always on the bottom. We need to know where you got that blood pressure from, what arm, right or left, and whether they were laying, sitting, or standing when you took it. So pain is according to the Joint Commission, the 5th vital sign, meaning with every set of vital signs, you need to check for pain. When not just how much pain you're in, not just that 1 to 10 scale that you always hear about. You need to know where the pain is. We need to know how intense it is. We need to know about the character. Is it burning or pounding or aching or, sharp pain, dull pain? We need to know how often they have this pain. Is it continuous or does it come and go? And we know how long they've had the pain. When did it start? We need to know all 5 of those things when we're doing a pain assessment. Otherwise, all you've gotten is their intensity, and you don't know anything else about that pain. There are automated vital sign machines, and I'm sure a lot of you have used them. You will not be using them in nursing school when you're in clinical. Okay, you will be taking manual blood pressures, etc. All right. Problem with these, yeah, you can get them real quick, and you can get the blood pressure and the heart rate simultaneously, and you probably get the temperature and the O2 sat at the same time, very fast. But automatic vital sign machines tend to give you results that are a little higher than normal, a little higher than it actually is. So that's why we're really kind of, if you get a really high number or a really low number off an automated vital machine, you need to go grab a blood pressure cuff and take it again manually. Okay. Couple questions and then I'll let you take a break. Okay. So Allison is taking the temperature of her patient. Which of the following is true when taking her patient's temperature?
Okay.
2.
Okay. Now we said when we had our rectal and our axillary temperature, axillary is usually 1 to 3 lower.
Oh.
Three.
3 is correct. You need to leave those glass thermometers in place for at least 3 minutes for them to be accurate. Okay, because there's no beep that tells you when it's done. So the answer here is 3. Allison's patient has a fever of 103 degrees Fahrenheit. She should perform all of the following nursing interventions to reduce her patient's fever, except, which means we're looking for something wrong.
One.
Correct. Yes. It is number 1. What do we want to do with fluid intake?
Increase.
Please.
You want it increased. Very good. You're taking your patient's pulse. Which site is most often used when taking the pulse?
Radial.
Radial artery.
Radial, yes. Okay. Allison's patient had a heart rate of 54 beats per minute. What is that? Tachy, Brady, arrhythmia, or normal?
Bradycardia.
Really?
Bradycardia.
Bradycardia, yes. Brady means slow. And which is not an appropriate guideline for measuring blood pressure?
1.
Sure about that?
They should sit or sit down.
It's 1. Have the patient
Okay,
lie.
so this is what we don't want them to do.
Yeah.
The
We
3.
don't want them to lie down or sit or relax for 5 minutes before we take their blood pressure.
You want them to do that.
You want them to do that, so that's not the answer we're
So
looking for.
3.
3.
Nope, that's right too.
2. You're not going to use the radial artery.
Very good. Somebody picked up on the cue. Radial. Radial's down here in your wrist. Do you take blood pressures down here?
No.
No, they're
No.
up here in your brachial artery.
Yeah.
Yep.
Okay, good job. All right, 10-minute break. Come back at 11:42. Okay? Okay. Everybody back? Turn the pretty cameras on again. Okay, so we're going to take our conversation now towards critical thinking. Chapters 4, 5, and 6 in your textbook. We're talking about critical thinking, and we are talking about the nursing process. I want you to write this down right now, okay? A D P I E. ADPI. Okay?
Are you?
ADPI is our ADPI is what we use. That's our acronym for our nursing process. A meaning assessment, D meaning nursing diagnosis, P is a plan, I is an implementation, and E is evaluation.
Can you repeat that, please?
Yeah. A is assessment, D is a nursing diagnosis, P is planning, I is implementation, and E is evaluation. Okay? This is the lifeblood of nursing. This is how we think. This is what we do all day long, whether you realize it or not. This is what you're doing. So let's talk about critical thinking first. Oops, wrong one. I already did that one.
How come I can't see the video?
No, I haven't got it up yet.
Oh, okay.
Come on. Yeah. All right. Can you guys see that? I think it's on the wrong screen. Back here. Oh, technology's fun. All right, can you see it now?
Yeah.
Okay. All right. So nursing process and critical thinking. So we're going to identify the components. We're going to compare them to clinical thinking, clinical reasoning, and clinical judgment. And we're going to talk about the problem-solving process and how to improve our problem-solving process. So when we're talking about critical thinking, we're talking about problem solving. Okay? Every one of you has solved at least one problem today, and probably more. Okay? So when you're trying to solve a problem, first of all, you have to identify what is the problem. What is the real issue here? Okay? Then we're going to consider all possible alternatives. So, and that doesn't necessarily all have to be you. If you're in a group, you can have other people make suggestions, right? Then we consider the outcomes for each alternative and predict the likelihood of each outcome occurring, and then take the alternative with the best chance of success and the fewest undesirable outcomes. So, what did you use your critical thinking for today? Anybody solve a problem this morning? Nobody?
We all did.
You all did, didn't you? You took a test, right?
Look at this, yeah.
Okay. So let's say you needed to be on time to take the test, right? But you're having problems with your Zoom. You couldn't get in. All right, and you're trying to get in, and you did the right thing. You started early enough so we have time to get in there. So what did we do? What did you do? What were the possible solutions to get to class on time?
Wake up.
Wake up helps, yes.
Yeah.
All right. So you had your alarm clock set. We got on and we couldn't get Zoom to come up on our phone or our laptop. So we used the other one just to get in so that that the instructors would know you were here. And then we worked out the problem with the other one, right? That was another solution we could use. This is one of the things I usually use as an example for critical thinking. So just think about this. I'm hungry. Okay, there's many different things I can do about that, right? I could stay hungry. I could go to the machine and get something out of the machine. I could call Uber Eats and have them send me something. I can call my husband and have him whip up a delicious meal and drop it off here at school. Okay, there are many different ways I could solve my issue. I'm hungry. Now, not eating, that's not a good solution, right? Because then I get hangry. We don't want that. Going to the machine, probably not the best solution either, because then I'm just going to eat junk food. Uber's a little expensive. I don't know about that. So then the last one would be calling my husband and telling him to bring me some food that he's made. That's probably a good solution to that problem, because I know he would do it. I mean, I've been married to the man for 40 years. I can expect him to do certain things, and that's one of them. Okay, so I identified my problem. I've given possible solutions to that problem. I evaluated each one of those solutions to see if the outcome would be that I would get food, and then I picked the one that was most likely to happen, right?
Mm-hmm.
So that is how you use critical thinking. And I'm sure you do it 100 times a day without even thinking about it. You know, you got kids to get dressed and up and out of the house, you got to go to work, you have to, you know, things that happen at work, you have things that happen at school, you do it 100 times a day. So it's not some big mysterious thing, this critical thinking. But we need it to use the nursing process successfully. All right. It's directed, it's purposeful, which ideas are evaluated, plans are constructed, and desired outcomes are decided. Okay. This is not just doing the first thing that comes in your head. This is getting all the evidence. So when we're problem solving, we first, we already saw that slide, never mind. So the skills we need for effective critical thinking is we need to be able to effectively read so we can look up solutions, right? We need to be able to write effectively so we can communicate. We need to be able to listen attentively because you're going to listen to other people's ideas. And then we need to communicate all that effectively in order to take care of our patient. So you're going to, when you graduate from school, you're going to have a certain skill set. You may not have the knowledge or the experience yet to do all of this at one time, but as you get further into your career, you will be able to do it based on your knowledge and your experience. And then we also look at our professional standards and our codes of ethics to see if we're making the right decision. So here is our critical thinking in the nurses process. Assessment. That's our first step in the nursing process, right? So when we're assessing, we're gathering information, just like you are when you have a problem. You're identifying, we need to get more information. And then we do a nursing diagnosis, which means we've analyzed the information and determined what the problem is for our patient. What is our patient problem right now? We take all our information and put it down, and we, kind of move it around and see what are the major problems for this patient. And then we plan. What is our desired outcome? What do we want to see happen? Okay, so we've assessed, we've identified the problem, and we've planned on what we want to happen. We want to see what our desired outcome would be. Then we have to implement our plan, okay? We have all the equipment we need. Do we have, what kind of interventions are we going to do to get to our goal? Interventions are things we do to get to our goal, actions that we take. And then we evaluate. So we're going to gather some more data to see if our expected outcome's been achieved. All of this is critical thinking. All of this is clinical judgment. Okay, but this is how the nursing process fits in. So, which of the following is an example of a nurse's statement that reflects using the scientific method in the nursing process?
Four.
Why do you say 4?
Because the patient already had symptoms of pain, but
The blood pressure.
Blood pressure is elevated, so they did evidence-based by taking her blood pressure.
Very good. Yes, we've gathered all our data, and it's not what somebody else thinks or what you think. You've gotten actual data to go on. So yes, number 4 is correct. So we use our nursing process and our nursing diagnoses to prioritize our care. So if we remember our Maslow pyramid, and the base of the pyramid is our physiological needs. And our first physiological need is air or oxygen and circulation, right? Anything that is a life-threatening problem, we are going to concentrate on first, all right? Everything else can wait. If they can't breathe, nothing else matters. Then we go into our medium priority problems, things that threaten their health or their coping ability, things like anxiety, their psychosocial issues, those kind of things. And then our lowest priority is going to be things that don't have a major effect on the person if we don't take care of it today. All right. So, maybe they need to have discharge teaching done in order to be able to do a dressing when they go home. Well, if they're not breathing, they're not going home. So we don't need to worry about that discharge treatment right now, right?
Yeah.
So high priority, life-threatening problems, medium priority, things that threaten health or things that they're at risk for, and then our low priority or other things that can be done tomorrow. So we use that to prioritize our workload. You're going to have 6, 8, 10, 12, 14, 20, 25 patients, depending on where you work. We got to stay organized. So when you're getting a report, you're gonna write out a worksheet and write down everything that needs to be done, the major tasks. You need to get blood glucoses. You need to pass meds. You have some treatments to do. We have somebody who's going to surgery today. We have, put those tasks down and then order them in order of priority. And we need to be flexible because I guarantee you the plan you make at 7 in the morning is not going to be the same plan you have at 8. You're going to frequently reorder your tasks and reevaluate your plan at least every 2 hours. And then you need to know when to ask for help, okay? If something happens and you get put off your plan because something happened to one of your patients, they crashed, they fell, there's something else going on with them that puts you way off your game plan, you need to be able to ask somebody else for help, and you need to know when you can delegate tasks to others, okay? So our whole goal is to avoid having any decision you make cause an injury to anyone, right? Do no harm. It's one of our first rules. So when we're using critical thinking skills, we weigh as many factors as we can to make good decisions the majority of the time. And if you start practicing this critical thinking model now, when you get into clinical, when you get into nursing and you're past your boards and you're a nurse, you will be able to provide safe nursing because you're already skilled at doing this. So here's our nursing process, which we already explained. So, assessment. What's the purpose of the assessment? We're going to collect all kinds of patient health data. We're going to get them all. We're going to look at many things to get that data. We're going to talk to our patient. We're going to look in the medical records. We're going to look at the discharge paperwork. We're going to look at and talk to family. We're going to gather data, okay, about our patient and about the situation. All right. Now you can do functional health pattern assessment. It depends on what you're doing at your job. Let's see, let me find that page. So if you look on page 58, you're going to find Gordon's 11 health patterns in a box 5-1. Okay, this is one way you can set up your assessment by functional health patterns. Okay, we're looking at there are 11 different functional health things that she's want to look at. All right, and some of them are, what is the health management plan? What is their nutrition like? What is their elimination like? How much exercise, how much activity can they do? What is their sleep and rest? Okay, so these things, and then we're going to assess what they're doing now, what they've done in the past, and what we want to get back to. All right, so those are Gordon's 11 health patterns, where it is focused on functional things that the patient needs to do. Okay, a focused assessment focuses on a specific problem. So if you have a patient who's complaining of nausea and abdominal pain, really doesn't matter how they were sleeping. It doesn't matter, whether they can get up and walk across the room. Right now, we're going to focus on the abdomen. We're going to focus on the GI system. That's a focused assessment. Okay, don't need to figure out their whether they're alert and oriented. We need to find out if they have bowel sounds, when the last time they ate, when the last time they pooped was. Okay, and then the basic needs assessment is based on Maslow. Okay, that's your breathing, your nutrition, your elimination, all those things on the bottom of Maslow's pyramid. I say period there. Then we're going to check the medical records, okay? What was the progress note? What's the H&P say? What kind of medications are they on? What kind of diagnostic tests do they have? What are their lab results? They show that they have an infection, okay? You need to know that. We're going to talk to our patient. And when we talk to our patient, there are 3 stages of an interview. This is not just, hey, how you doing? You know, like you ran into somebody in the donut shop. We're going to be talking to these people. We're going to be asking questions that are fairly sensitive. So we have to get some rapport. All right, establish some rapport with the patient. You know, make sure that they know that you're there for them, that you're going to help them, that, you know, we're doing everything we can, those kind of things. And then you go into the body of the interview. And this is where you're going to ask those necessary questions. Those questions like, when was the last time you had a bowel movement? What does your urine look like? Okay, do you use protection do you have unprotected sex? Do you use any drugs? Are you a cigarette smoker? How much do you drink? These are sensitive questions. Okay, those will be in the body of the interview. That's because we're gathering data about this patient. And then our closing is we're going to, you know, summarize what the patient thinks her problem is. Okay, so why are they there? You're here for this, and this is what, you know, pertains to that. Summarize the information. Just because when we're communicating with someone, you want to make sure you're both on the same page, but before you leave the room. Subjective versus objective. Okay, subjective information is what the patient tells you. I have a headache. I have a stomach ache. I don't feel good. I have, you know, this, anything that you cannot visibly see is subjective. Okay, nobody when they have a headache has, you know, headache pain printed across their forehead, right? It's not there. You can't see it. You can't touch it. You can't feel it. You can't replicate it. Okay, that is subjective. So whatever the patient tells you is a symptom. So I have a sharp pain in my hip. I haven't been feeling good lately. Those are subjective information, and we call that symptoms. Objective information is information you obtain from your physical assessment. So somebody says, I have a headache, and you take their vital signs and they have a temperature of 100.1.4. That is objective information, because you can come back and take their temperature again and see if it went up or down. All right, it's not that vague. I have a headache, I don't have a headache thing. All right, so that is called a sign. So when we say signs and symptoms, we're talking about both the subjective information you've gotten from the patient and the objective information you have gathered. All right, and after we've gathered all our data, we're gonna analyze it. We're gonna put it in groups. We're gonna ID anything that's missing, like maybe we don't know when the last bowel movement is because we forgot to ask. We got to go back and ask that question. Okay, we need to look at the medications, things like that, and we're going to make inferences relating to the patient's problems. We're going to infer what is going on with your patient. Now, it is not your medical diagnosis. That has nothing to do with it. It has a little bit to do with it because it puts you on the right path. But nursing diagnoses should be the next one. Oh, never mind. Okay, so we've gotten all our data. Now we're going to do a physical assessment. And when we do a physical assessment, we're going to start with inspection. You're always going to look at it, look at the patient. Are they breathing normally? Is their skin, you know, the right color, that sort of thing. Then we will listen. We will listen to the heart, the lungs, the bowels. We will palpate, which would be feeling. And then percussion is the last part of your assessment where you're drumming on something. And so you're taking your fingers and you're tapping on your fingers. And if it's supposed to be, if it's hollow sound, that means there's air there. If it's a dull thud, that means you have an organ there. Generally, as LPNs, you're not going to go that far. All right. But you will do inspection, auscultation, and palpation. Head to toe, usually is systematic. You don't want to jump from, you know, checking their eyes to checking their feet, right? Keep it organized. And once we have that data, we're going to develop our nursing diagnosis. So what is the problem the nurse needs to take care of? These nursing diagnoses were developed by NANDA, which is an organization that writes nursing diagnoses, back in the 50s, because they determined that nurses need to take a more active role in patient well-being, in patient care, in patient decision-making about what to do for the patient. So this is our nursing diagnosis. It has nothing to do, we're not using our medical diagnosis. So a nursing diagnosis statement indicates the patient's actual health status or the risk, the causative or related factors, and the specific defining characteristics. So, identify the appropriate diagnosis. Let us say that your patient has a sacral ulcer, an ulcer on their backside that is open, draining, yellow drainage, and has a lot of pain. Okay? So we have identified that the appropriate diagnosis here is not the sacral ulcer. The nursing diagnosis would be impaired skin integrity. So what's causing this ulcer? Well, it's related to immobility. The patient had a stroke, they can't turn themselves, they can't feel, they have, loss of sensation in that area. So it's impaired skin integrity related to immobility. And then defining characteristics. These are your signs and symptoms. As evidenced by. AEB means as evidenced by. An open area on the sacrum, reddened areas on pressure points, and then you can add patient unable to turn and reposition themselves, okay? Or it could be impaired skin integrity related to poor nutrition because the patient can't eat, all right? There's a lot of different things this can be related to. You have to determine what it's related to. So a proper nursing diagnosis would be impaired skin integrity related to immobility as evidenced by open areas on the sacrum, reddened areas on pressure points, and whatever else you got in your assessment. These are your signs and symptoms. And then once we have our nursing diagnoses, we're going to prioritize them based on our physiological needs. First thing we're going to do is take care of the physiological needs, and then the safety issues, and then the psychosocial issues. Okay, so which of the following sets of assessment data is most likely to be present with a nursing diagnosis of risk for infection?
Fever.
The last one, abdominal incision, decreased hemoglobin, and indwelling catheter.
Right. Okay, why is it not one? Why is it not the first one? And do they have a risk for infection?
No.
No, they actually have the infection, right?
Mm-hmm.
That is a urinary infection. But we learned last week that anybody who has an incision, anybody who has a catheter, anybody who has low blood counts is at risk for an infection, right?
Yes.
So that's why that's the appropriate nursing diagnosis. Okay, we will end here and just wrap things up a little bit because I don't want to run over and I don't want to get involved in anything. So we talked about critical thinking. We talked about the steps for critical thinking. We talked about practicing critical thinking while we are in nursing school so that when we get out, we can do it much better. Then we moved into assessments. And what are the three pieces of the assessment?
Assess,
No?
Collect patient health.
Okay, we're going to, yes, collect the data from the medical record.
And pull.
Talk to family.
talk to the family, interview the patient, and then evaluate what we have to make sure we have all the information, right?
Mhm.
And when you do an assessment, a physical assessment, we're going to inspect, auscultate, palpate, and percuss in that order.
Can you repeat that again, please?
When you're doing a physical assessment on any body part, you're going to inspect, you're going to look at it. You're going to auscultate or listen. You're going to palpate or feel. And then the last one will be percussion, which is where we're identifying organs and open areas inside the body. And then the 3 parts of a nursing diagnosis. First, we have to identify what?
The problem.
The problem. Yeah, we can look at our assessment data and determine what the problem is. And then we have to determine what?
Eh, choosing the appropriate diagnose.
Okay, we've gotten our appropriate diagnosis, and that's going to be related to something, right? So we have to find the problem and what's causing the problem. That's the second step. And the third step is putting down all the signs and symptoms we have that tells us, yes, this is what the problem is and what's causing it. Okay, so you have a quiz next week. It's on chapters 4, 5, and 6. All right, we're not going to be able to finish up all those chapters today. We'll probably touch on them again next week, but when you're preparing for your quiz, skim those chapters, look at the important things, look at the boxes, and do the questions at the end of the chapter.
Okay, and it's 5, 6, and 7.
4, 5, and 6.
4, 5, 6.
Okay,
This is
so
number
is there anybody
21.
have any questions or any other issues?
I'm fine. Thank you.
Are we doing 21 too? Are we gonna have that in the test?
It might be.
Okay.
I won't guarantee it isn't. Okay, any other questions? How you guys feeling? Feeling okay?
I feel good.
Ready to move on?
Yeah.
Thank
Okay,
you for your time.
you're welcome. So, lab starts at 1. Use the same Zoom, okay, to get back here. You're gonna need your math book. You're gonna need that little baggie with the little plastic cup and the syringe in it. And you're gonna need some tablespoons and teaspoons that you have at home. So whatever you use for baking or eating or whatever, okay? What else you gonna need? And then you're gonna need your blood pressure cuff and your stethoscope and your thermometer that is in your nursing lab kit. Okay, so you have some things to gather for lab. All right?
Mm-hmm.
All right, so I will see you all at 1 o'clock. Don't be late. All right,
I'm sorry, Miss Novak, you said the test grades will be available when?
Wednesday.
Okay, thank you.
You're welcome.
Professor Novak, will I be able to make up the exam?
Yes.
Thank
Yes, I'm gonna try and arrange something for the makeup exam. Okay?
Okay. I
I
appreciate
will
that.
get
Thank
back
you.
to you.
Okay.
Any other questions?
Well, thank you, Professor.
The
You're
math,
welcome.
Have a
I have
good
a
day.
question.
Yes,
So the math, did you want us to take a picture of all our answers or just a certain amount? I wasn't clear about that part.
you can just send me the last page. It's fine.
Okay, all right.
Any other questions? All right, guys, I'll see you at 1. Okay?
Bye.
Bye. Get some lunch.
If it grows.